Hi, this is Zach Allen. This is going to be my analysis paper video. My paper is over hyperkalemia and hyperkalemia treatments in the pre-hospital setting. So yeah, I'm going to be going over that. The paper is going to go over the pathophysiology of hyperkalemia as well as possible treatments for the condition. Hyperkalemia is a complex condition that requires multiple medications to treat effectively. So your service might not carry all of the medications that can be used for hyperkalemia, but with the list of the drugs that can be used, the certain ones that you do carry, you can use. So hyperkalemia is defined as having more potassium in your blood than normal. Potassium is a chemical that is needed for the function of nerve and muscle cells, including ones in the heart. So, potassium, the sodium potassium pump, I'm sure a lot of people have heard about that. It's needed for that. So if you have an overabundance of it, it can cause, heart issues. Normal blood potassium levels are 3.6 to 5.2 millimoles per liter. Any levels above 5.2 are considered hyperkalemic. If you break that word down, hyper, above, Kal, which is, potassium, K, and then emia is, blood, so high blood, or high potassium in the blood. The typical person to develop hyperkalemia are people that are in renal failure and or require dialysis to eliminate waste from the body. So if they're unable to get rid of waste within their body, anytime they get potassium in their blood, it's not going away unless it's used by the cells. So if there's an overabundance and it's not getting used by the cells, it's not getting wasted like normal people because they have renal failure, and that's where you excrete waste, is through your kidneys and bladder, and it gets excreted in the urine. So dialysis is a medical treatment that pulls waste out of the blood by taking the patient's blood out of their body, running it through a machine that filters the blood and gets rid of the waste products within it, and then infuses the blood back in the patient's body. There's surprisingly a lot of dialysis patients. There's a lot of dialysis centers throughout the country where people go and do this 3 times a week, multiple hours a day. Often 3 to 5 hours long each time. So normal potassium is critical to having normal electrolyte or a normal electrical heart rhythm. Abnormally high potassium levels can cause issues with the heart's electrical system. One way to assess for hyperkalemia is to check an ECG on a patient that is suspected of hyperkalemia. If the ECG shows peak T waves, that's a possibility for hyperkalemia. Hyperkalemia can also suppress heart's electrical function, and in extreme cases it can cause cardiac arrest. Therefore, a good assessment is crucial, and early recognition is needed to prevent adverse outcomes. There are multiple causes for hyperkalemia. Kidney disease is one cause that was mentioned earlier with dialysis. A diet that is high in potassium is another cause, but typically that's only in patients that have renal issues, because you can excrete the extra potassium that gets eaten in your body. Typically, if you have more than what you're supposed to, it can be excreted. Foods such as cantaloupe, honeydew melon, orange juice, and bananas are all high in potassium, all those fruits. There are also drugs that prevent the kidneys from losing potassium, which causes retention of potassium and thus hyperkalemia. Other causes such as taking too many potassium supplements, Addison's disease, burns, diabetes, all of these can result in it. Some symptoms of hyperkalemia can include muscle weakness, numbness, tingling, nausea. If you're just barely above that 5.2 level, a lot of the time you won't have symptoms. A lot of these symptoms are coming from a large amount of potassium within the body. So a person with an elevated potassium level could have an ECG similar to this one. Everyone's ECGs are different. I'm sure people have seen that. But I have a picture here on my paper that shows peak T waves, which is an example, which is what a lot of people associate with hyperkalemia. There it is. An ECG that has peak T waves can be treated in the pre-hospital setting. One drug that can be used to treat hyperkalemia is calcium chloride. Calcium directly antagonizes the effects of hyperkalemia without lowering the potassium levels. It stabilizes the myocardium. It does this by reducing the threshold potential of cardiac myocytes, thereby restoring the normal gradient within the membrane resting potential. The recommended dose is 10 milliliters over 10 minutes. EKG should be monitored due to it acting on the heart. Anytime you got heart issues, you want to be monitoring that. Even if it's a potential side effect, you need to monitor it, because the time you don't monitor it is the time that it's going to mess stuff up. There are some cases of sudden death when patients were given calcium via IV while also receiving digitalis glycosides. Be sure to administer calcium under close supervision. Don't just be giving it willy-nilly like you would some other weaker drugs. Hypertonic saline has also been shown to help with hyperkalemia and can reduce the EKG changes seen in hyperkalemia patients. The effect caused by a change in electrical properties of cardiac myocytes rather than by a reduction in potassium. Insulin has been shown to reduce potassium in patients with end-stage renal disease, causing potassium to shift into the cells. Its effect is dose-dependent. Little known fact, you can give albuterol, which is a beta agonist. You can give that via IV, not the stuff that's built for nebulizers, and it's not even available in the US, but there is IV albuterol, and it can cause a decrease in potassium. So if they're hyperkalemic, that's something you would want. But nebulized albuterol also works. It just takes a higher dose than what you would give for a breathing treatment for it to actually do a significant reduce in potassium. Sodium bicarbonate is another drug that's effective in treating hyperkalemia. Sadly, studies have shown that it is not effective unless there is a 4-hour treatment of bicarbonate, such as in an infusion, and there's only a small effect whenever that's done. So just giving that amp of sodium bicarb, while it is in a lot of people's protocols, it wasn't shown to actually improve hyperkalemia. The pre-hospital signs and management of hyperkalemia is what I'm going to get into next. The classic progression of ECGs of hyperkalemia are a peak T wave, which was shown earlier. This reflects faster repolarization of the myocyte. A sensitive sign is if the T wave exceeds the R wave, so you can measure those and determine that. The next is a prolonged PR interval and flattening or disappearance of the P wave. So the P wave comes before the QRS. That's the atria of the heart depolarizing. So if that's gone, then obviously you know you have a heart issue, because now the atria is not depolarizing. The resting potential of the myocyte becomes more positive, which slows depolarization. The third step is the widening of the QRS. The increasingly positive membrane potential leads to progressively slowed depolarization and widening of the QRS. The fourth is the sine wave, otherwise known as a pre-terminal rhythm. As the depolarization slows, the widening QRS begins to merge with the T wave. This can deteriorate rapidly into ventricular fibrillation, which results in cardiac arrest, which is definitely not something that you want to happen. So if you start noticing a sine wave, which is where the QRS is merging, like I said, with the T wave, this is pretty much right before ventricular fibrillation. Determining the cause of hyperkalemia can be difficult, and it's typically not done in the pre-hospital setting. You can gain a history if they tell you, But I mean, it can be from medications, renal failure, cell death, massive transfusions, crush injuries. It can be a ton of different things, and it's important to get a history, but you might not be able to determine it at your level. There's three main principles for treating hyperkalemia. One is to stabilize the cardiac membrane, which is done with that calcium. The second is to shift potassium intracellularly. If you do this with insulin and glucose, the insulin helps with glucose going into the cell, which also has potassium going to the cell as well, which helps bring the potassium into the cell, which is where it gets used up. And then third, eliminating potassium is done by giving fluids, getting a Foley catheter, and making sure the patient has adequate urine output, because this is where the potassium is going to be excreted from the body that isn't used. Overall, this is a complicated medical condition. Multiple problems can happen at the cellular level, and it can result in death in extreme cases, especially if it goes untreated for a long time. If you have the ability to stabilize this patient before heading them to the ER, then you need to. If you have these drugs available and you're confident enough in giving this and it's in your protocol, there's no reason not to. So this was my paper on hyperkalemia.